Hello, everybody. Welcome to the first of the four session series of Kion Foundation's webinars, which are focused on community focused approaches to promote resilience and mental health. Um, I guess people are in process of joining, so I use the first couple of minutes to introduce Calm Foundation and the kind of work that we are doing and the goal of this series. And hopefully by that time, we have a quorum to start. So Kion Foundation is a humanitarian nonprofit organization registered in the United States with the main goal of promoting health and human rights for people in crisis. Kion Foundation was initiated in support of the Women Life Freedom Movement in Iran and is named after Kian Pirfalak, who is an amazing 10-year-old boy who was killed during the protests. The mission of Kian Foundation is to promote health and human rights for people in crisis worldwide through education, empowerment, advocacy, and support. Kian Foundation strives to build capacity and provide access to resources and assistance to those in need while amplifying the voices of the people in crisis and fostering the culture of respect, inclusion, and justice for all. Again, given the history of Kian Foundation and our primary language, many of our services are translated and also focus in Farsi-speaking culture and Farsi-speaking languages. But this series that we put together, we invited an amazing basically a group of hosts focusing on different aspects of community resilience and mental health. I will share the first slide, which is basically an introduction to the series. Our four-session series are basically distributed across July and August and September. Today, we are fortunate to have Dr. Carol Lewis from University of Florida. She will be focusing on improving community behavioral health with the Community Wellbeing Mentor program, an amazing program that she initiated, and we hope to learn more about that today. Our second talk will be on August 6th, and we invited Jess Kohler, who is one of the leadership of an amazing community-based organization focusing on trauma-informed community change. And basically, he will introduce activities of the organization focusing on vulnerable populations to activate community action and community change in the context of resilience. Our third talk will be by Dr. Ida Castro on August 20th. She's a psychologist, and she also designed an intervention focusing on community health workers and also community-based interventions focusing on connecting people and connecting communities with the focus on mental health in the context of cancer. We hope to learn about that initiative and basically use it in other contexts. And our last talk will be Dr. John Drury. Dr. Drury is a social psychologist, and he will talk about the psychology of collective resilience and lessons learned from recent crises, including COVID and other crises, and how people work together to address those challenges. Again, as I said, we are fortunate to have Dr. Lewis today. She is a clinical associate professor at University of Florida College of Medicine. She is a psychologist and also a public health researcher and practitioner with more than 37 years of clinical experience. She has developed several programs, including a community wellbeing mentor training program aimed at increasing community wellbeing and emotional health by training community members to teach simple skills for emotional health and well-being to their friends, neighbors, and peers. Before I hand over the podium to Dr. Carol, a couple of housekeepings. You can use QA, so there should be a menu or a button for QA for question and answer at the bottom of your Zoom screen. So you can type your questions. I will monitor the questions and I will ask questions at the end of the talk. We hope that this session will be for an hour with 40 minutes talk and 15 minutes opportunities for conversation. So I stop sharing and hand over the podium to Dr. Lewis.
All right, so glad to be here with everyone today from probably far and wide. And so I am a clinical psychologist. I consider myself a public behavioral health practitioner. I have a PhD many years ago. That's at 37 or 38 years of clinical practice. And then more recently, although a decade ago, a master's in public health. And so I have, in the last 2 years, developed this Community Wellbeing Mentor program, but I've worked in public behavioral health for a number of years. So we're gonna go over a number of different things today, and then perhaps we'll have some time to look at some parts of the Community Wellbeing Mentor program. And these are things that we offer. This is work also through something we call the Mobile Outreach Clinic. And in Gainesville, Florida, in the US where I am, we have a bus that goes around and provides free primary care, and once a week this year provides behavioral health care for free, and that's me. We're doing even evidence-based treatments for trauma, such as EMDR. We're doing that virtually at this point in time since COVID. So let's begin. And so I love this quote from Donald Berwick at the Institute for Healthcare Improvement. You cannot give what you do not have. And this is just our call to take good care of ourselves. And so as we do this difficult work, helping to reduce suffering in ourselves and others, very important to take care of ourselves at the same time. So most of you are aware of Maslow's hierarchy. Let's remember this is from 1943, so it's been around a while. And I think it still has relevance. Just let's think about, what do we need to be healthy? And so in this hierarchy, we start off with those basic things like food and water, those very basic opportunities for sleep, safety, and security. So when those are not being met, we really can't navigate up the hierarchy to other things. So we do know that we need to meet basic needs as well. Oh, let's see here. And so I thought we could talk for a minute about trauma and distress, and then we'll talk about resilience. Often, I'm part of a trauma responsive resilience building initiative here in our community. And when we talk about trauma, we also talk about resilience, but I think to talk about resilience without trauma, sometimes it leaves the context out a bit. So there's a lot of different ways people talk about trauma and distress, but I will remind us that stressors are not the same as distress. We can have a number of people who experience similar stressors, and their levels of distress may be quite different. And what's different is the people in the middle, the tools and skills, etc. Other ways to think about trauma are when our systems get overwhelmed by experiences that are too much, too fast, too soon. You can put some other twos in there too. And there isn't enough time to integrate the experiences. Another framework looks at 3 types of traumatic experiences. Acute, let's say someone had a car accident yesterday, so there's a thing that just happened. Chronic conditions over time. And then complex trauma, which is also sometimes thought of as developmental trauma or multiple traumas in a row. I put this here just because sometimes we're talking about apples and oranges. And so people will say, what is trauma? Is this the same as this? And they're just different ways to think about it. And if we think about it as our systems being overwhelmed from whatever these difficult experiences are, I think that can be very useful. There is a social worker in the US named Resmaa Menakem. He wrote a really wonderful book called My Grandmother's Hands, which he remembers his grandmother and her hard work. And I heard him present this trauma framework, this HIP model, which I really like. So trauma can be historical, things that happened many years ago in the US. This could be our history of enslavement. It can be intergenerational, and we know now passed along in our epigenetics often. It can be persistent institutional, and that may resonate with a number of people, and then also personal. But often in trauma circles, we think we put the defect in the person. So it's the person who is traumatized when really it can be the context there that is traumatizing. So we want to be careful not to decontextualize, why am I feeling this? It's because there's something wrong with me. And maybe because of one or more of these experiences that I've had. And so people also, I'll just put this on the screen. This is another way people think about trauma. And this isn't my framework, but the natural disasters or war or various deaths of loved ones, big T trauma, sometimes how they talk about it. I don't really use this terminology, but little T trauma. I've worked clinically with a lot of people who've had dog bites or been in healthcare situations that were traumatizing to them. And then also community or cultural traumas that perhaps can be experienced by the individual, but they're over time. And it may also be cultural factors that we live with over time or we have experienced. And so when the nervous system becomes overwhelmed, like we talked about, people can lose the capacity to stabilize and regulate themselves. So then it shows up in the personal, but the antecedents are out there and are other things. So if we look at resilience, and there's a whole resilience science, but here are some ways to think about it. It's the ability to weather both easy and more difficult circumstances. There are palm trees on this slide because they can bend but not break. They're strong and stable the way that they're built. And so we've got, where I live, other kinds of trees that if we get hurricane force winds, they're going to topple over or break. And so resilience is the capacity to recover quickly from difficulties, to be strong and stable, to bend but not break, to bounce back. And yet, a lot of people talk about moving from resilience to thriving and joy. So we want to bounce back, but we want to have the capacity to find joy in our lives as well. And so this is in some sense, for those of you who are academics, we would think of this as a socio-ecological model. And it just says, here we have a person. They're in a family, perhaps they're in a relationship. Their family may be extended. They may be at a school or an agency or a work culture. They're in a community. Then we've got the context of the larger world. And the things that are experienced in one of these circles can resonate and impact the others. And so I just put a few terms here that when we're looking at trauma and we're working with people who have experienced some of the things we talked about earlier, there may be compassion fatigue, burnout, vicarious trauma. Remember, you can't give what you do not have. So very important for us to take care of ourselves. But in the resilience world, now people are talking about beating the odds while changing the odds. So that's resilience plus social justice. So resilience of the individual or the system. So the individual could be more or less resilient, the family, the school or agency, as well as the community. There are resilience cities. So there was an initiative called, I think it's 100 Resilient Cities. And what it means for a city is to have systems that have good backups. I'm in a place where there are hurricanes. So there's not just one system, there are multiple ways that can be stabilized and some flexibility. We can have vicarious resilience as well as vicarious trauma. So if I am resilient, it can rub off and be transmitted to those that I'm around. And I think that's really important to know. So we want to keep things in context, both with regard to trauma and resilience and well-being. But I really love the beating the odds while changing the odds. So we're going to help ourselves be the most resilient we can be, and our communities and circles, while working to change the context that are in the victimizing, traumatizing conditions. Really important. This is really just to show you the details of this slide are not important, but you can work on resilience. Let me go back to the previous slide. You can increase the resilience of any of these circles and whatever other circles we might have put on here. So this is just one model of individual resilience from these authors many years ago. And what I find to be most important on this slide is a factor that can be confusing to a lot of us, and was for me when I first started down this road understanding resilience, which is that there's not just one thing. There are things that are internal. This is from an individual point of view, things that are internal to us. And so that on this model, it is social competencies, values, talents, interests. I put on here mindfulness, social emotional learning. I added that to their model. My apologies to the authors there. And then external things. And so what you find on almost all the individual resilience models is this idea of a secure base. If you're children, it's having a relationship with one or more adults that's stable and healthy. We can think of that in our adulthood, other people we're connected to that provide stability. It's not just one kind of thing. Our stable base or secure base can be made up of many different possibilities depending on our context. And then here, external education, people that we might have relationships there with, friendships, etc. So really, individual resilience is internal factors and external supports. Important to know. And so there are so many models of individual resilience that it can be hard to know really what's most important. But from Jack Shonkoff at the Harvard Center on the Developing Child, they have put forward these 4 factors. And again, this is now individual resilience, but I think this is a good sort of summary in the individual frame of reference. And so secure base is a really important individual resilience factor for children, stable and supportive adult-child relationships. So that's an external resource. A sense of self-efficacy. So that means I do something and it creates an impact or an effect. Also, these are sort of summarized from lots of research by lots of people. So self-efficacy, I do something, there's an effect, that's a skill and a way of thinking. Adaptive skills and self-regulatory capacities. This is coping skills, tools and skills. Again, tools and skills. And then sources of faith, hope, and cultural traditions. Resources external to ourselves help create that stability for ourselves. So from some work by George Bonanno, who is at, I think he's at Columbia in New York City, and he is a set of researchers. He's been researching resilience for a very long time, not a clinician, but a researcher. And he's part of a group that were in New York City when the 9/11 tragedy happened, and they were able to study a lot of what happened and then for many years afterwards. And so one of the things that they say, and his book is, I think, referenced on one of my slides, The End of Trauma, is that our individual resilience trajectories don't all look the same. And it's impacted by a number of factors, which we'll talk about, including our ability to be flexible and bring what is needed to a situation. It's not just one thing. To pay attention and assess as we go and adjust accordingly. And also this very important research finding, which is that most people who have traumatic experiences don't develop something that looks like PTSD. There is, I think, sort of a cultural belief, perhaps here in the US, that if you have a traumatic experience, it equals an experience of PTSD, but that is not what the research shows us. And so what it does show us, and here's George Bonanno, The End of Trauma. It's an excellent read. And it's really for anyone. It's not just for researchers. That after traumatic experiences or stressors, 2/3 of people on their own are resilient. So 2/3 of people bounce back on their own without clinical intervention. The other third take one of 2 trajectories. So one is that they gradually recover over time. It takes them longer. And so for the 2/3, it does not mean that they're not impacted. They are impacted, but they are able to bounce back in a reasonable amount of time, whatever that may be. And I won't define that. But others, another part of the other third gradually recover, but it's a much longer period of time. And then we have the portion who have chronic difficulty, including PTSD. So it's not everyone that will experience the symptoms of PTSD. And I don't know if I clearly mentioned earlier that that is one of my areas of expertise and what most of my clinical work is at this time. George Bonanno also talks about in their research, so they're looking at all of these different resilience factors. Everyone's looking for the thing, right? What is the thing that makes you the most resilient? And so what he and his colleagues have found is that really what it is a mindset and some tools and skills. And so the mindset has these three beliefs. So the first is optimism about the future, different than hope. So hope is good, but it sort of says, you know, maybe this will happen. I hope it does. Optimism is I can be okay. Like I can manage whatever this is. I can do it. Then confidence in our ability to cope, that things will work out and I can manage and I will manage, not without difficulty, but I will manage. And then a challenge versus a threat orientation. So viewing what is around us as challenges versus threats. When we do not have these, we often kind of cave in on ourselves, right? The threats are overwhelming. I can't cope. Things are going to be terrible. Then you would be less resilient. So that's the flexibility mindset. And then he also talks about the flexibility sequence. How are we to be flexible? And there are 3 steps as well. And they're pretty simple. What is needed in this situation? That's context sensitivity, not just what is needed in every circumstance, but this particular one, what is needed? Then what am I able to do? Hopefully there's a repertoire of healthy and effective tools and skills. And then as you go along, some sort of feedback monitoring and adjustments. Is this working? It's not working. Let me try something different. Hopefully my repertoire has other things. So different responses are needed for different situations and at different times. So that's sort of some background on trauma and resilience, the different ways we think about things. And now I'll talk for just a minute about this. This will relate to, as an example, to mental health in the United States. And there are, despite the affluence of our country, there are many unmet mental health needs in our current service delivery model, which is really a fee-for-service kind of model. The reference for the next few things I'm going to show you is Mental Health America. They're a very legitimate research organization. Their information is as good as the CDC as far as I'm concerned. And so here's a link to this information. And so in the US, there are 350 individuals for every one mental health provider. And probably most of you, or maybe some of you who signed on to this, know that not everyone has health insurance here. We do not have a public health system like exists in so many places. So there are plenty of people who don't have coverage for these things. And so different kinds of mental health providers are included here, but there are 350 individuals for every one mental health provider. This is information from June 2022. There are over, in the US, over 152 million people who live in a mental health workforce shortage area, and only 28% of the mental health need in the shortage areas was being met by mental health providers. And so here's some more of the data. And I just was going to highlight a couple of things, that the ones with the asterisks, 21% of adults in the US are experiencing a mental illness, equivalent to over 50 million Americans. 55% of adults with a mental illness receive no treatment, over 28 million individuals. 16% of youth report suffering from at least one major depressive episode in the past year, and 60% of youth with major depression don't receive mental health treatment. So we're doing a very poor job of meeting the mental health needs, even in this country, the US. So this is a stepped care model. So we're coming around to the community behavioral health ideas here. This is from the UK. And so this is from their increasing access to psychological therapies model. So they have a whole population coverage idea. And so it goes from prevention up the steps to recognition and universal assessment for mental health issues, to in the primary care setting, watchful waiting, guided self-help. Then there are mental health workers embedded in primary care, perhaps. Then you have more specialist care, and then on to crisis teams and perhaps psychiatric hospitalization. In the US, we really come in at more of step 4. So you're on your own a little bit, steps 1 through 3 and prevention. We come in at step 4, where you might be able to access some individual or group therapy. In my community, which has an academic medical center, most of our community behavioral health providers are self-pay. So you might have to pay $150 per session. I mean, that's out of the question for me. And that's for a lot of different reasons. So as an upshot of this, really, what can we do that can meet these behavioral health needs in a more effective fashion? And I just have listed over here, there are some models that do things like put a mental health practitioner down the hall in primary care, or some couple of other models, but I don't think they have a lot of traction, and they're not that innovative. So I think it's great, have a psychologist down the hall, but that's not going to do very much in the big picture. So then we look at these task shifting models. And so this is one I love from Zimbabwe, called the friendship bench. And so there in Zimbabwe, they had not very many psychiatrists. And so a psychiatrist there said, I'm not going to be able to meet the mental health needs of the broad area that I'm supposed to be working in. And so he gathered some trusted community members and gave them training in some mental health strategies. So if he was looking for trusted community members, I just want you each to think, who would that be? So who is a trusted community member? And I'm actually part of this group. So he looked at grandmas. And so he trained grandmothers in some evidence-based strategies. He put them on benches, certain benches. Initially, I think they had vests. It looks here like they're not having vests anymore. And people, I'm not sure, I think they could make appointments. And all in all, when you looked at the friendship bench strategy, oh, pardon me, the outcome for the grandmas was better than the psychiatrists, just saying. And you can find a lot of information on the friendship bench. Here's a reference at the bottom. It's considered an innovative project, but it's task shifting, taking ideas, tools, and skills out into the community and not waiting, in my context, for people to be distressed and ill enough that hopefully they have some resources and they can end up with me or perhaps through our mobile outreach clinic. So in this way of thinking, I've developed the Community Wellbeing Mentor program. And this is a task shifting model. It teaches community members or agency staff to be community well-being mentors. I didn't bring in one of my pins, but I give out pins that look just like this graphic here. You get a certificate and copies of tools and skills to use with me as your backup, that you can contact me at any point in time. So this is the flyer we give out. Are people interested in learning skills to improve emotional health? These are tools and skills I teach in my office clinically, but why do we need to wait for that? Why can't we take these out to the community? So we're asking people to learn these and take them out to whoever their circles are, their neighborhood, their church, their mosque, whatever it may be. They could be the person in their agency who's a community well-being mentor. The training is an 1.5 hour session. We started with a much bigger idea, and this is what we have found over the 2 years we've been doing this, that's acceptable. We give all the materials, there's no cost. We're going to learn things like focused breathing, grounding, healthy lifestyle habits that I will tell you, as a mental health provider of almost 38 years. If we skip that stuff and we go directly to let's solve the issues and the problems, but we don't talk about how to regulate and manage yourself and how to solve those problems, we're really going nowhere. That's my belief. And so far, in this project started the beginning of last year, really, I had ideas. We got some funding from an organization called Direct Relief to focus on this. So from project beginning and developing the curriculum, it was just the beginning of 2023. We've had 22 trainings. 275 people have been trained either in person or online. I'm available to do either one. We have trained individuals, staff from homeless services centers, food bank staff, domestic violence service center staff. And these aren't the clinical staff, for the most part. These are the security guard and the person at the desk and whomever else it may be. An organization called the YMCA. There's a community fellowship that's focused on poverty reduction. I did a training for a Burmese immigrant group with translation as we went. I've trained some clinic medical staff and also Center for Independent Living staff. It's an organization, a nonprofit agency that's working with people with disabilities. So that's just a list of some of the folks we've trained so far. And so feedback, people have said this is so helpful. Again, we give extra copies of everything. And I'm also willing to give the electronic files to people after the training so they can make them their own. It's in English, but we have everything translated into Spanish, and some of it was translated into Burmese for that population that's from present-day Myanmar. But I'd love to have someone translate this into Farsi. And so I've already told you really what the project is. This is our table of contents. And in an hour and a half, we're going over why this project, some basic tools and skills. There are some teaching tools on heavier cardstock in the folder and some extras. Some of them were developed by me, but some are from other sources of things. So nightmares, there's a nightmare reprocessing tool. That's maybe not relevant to everyone, but I have had a number of people get back to me and say, I was talking to someone and they said they had nightmares, and I was able to give them this strategy and this tool and skill. So I'm not training people to be mental health professionals. I'm giving them basic tools and skills that are human being tools and skills and supporting them as they go out into the community. The basics, we start with this idea of how do we know how we feel? So in mental health, most people think, oh, it's the emotions, right? Of course. Well, even if in our clinic, we screen for depression and anxiety when you come, at least I do, for every visit. We use an open source tool that's used around the world called the PHQ. We use the 9-item version, and the GAD, we use the 7-item version used around the world. And those 16 items map pretty directly onto diagnoses of depression and anxiety, but only 3 of the items directly reference mood. The other 16 are about thoughts, body sensations, and behavior. So we have habits in any given moment in each of these categories, emotions being the fuzziest, and they're all related to one another. I might have a thought, my body might start to respond, I do a behavior. If anyone's heard of cognitive behavior therapy, you can just chop off the body here, and that cognitive behavior therapy, which is a modality I use, and it was very innovative and has a lot to offer, but it talks about how thoughts, emotions, and behavior are related to one another, but what happened to the body? So the good news is that we can enter any of these, especially 3 ovals here, to begin to make change. If we're aiming for the oval of the emotion, it's really going to be hard to get any traction. But keep noticing this oval of the body sensation. Oh, first though, before we do that, here, so So this is given as a teaching tool on cardstock. It's in the manual, which is, I think, just 22 pages, and they're given copies of this, extra copies to hand out. On this copy, this is one side, and the other side is this, how do we know how we feel? And so this resilience plan asks us to begin to notice the early warning signs of difficulty in those 4 areas we just talked about: in the body, in the thinking, in the behavior, and in emotions. And then, in a proactive kind of way, we want to come up with healthy actions to take in each of those areas. So we want to have something for everything written on the left. We want something on the right. Next to in my emotions, there's some tiny words that says healthy actions in this area are really made up of things in the other areas, because that's really, the things you do to manage your emotions are really in the body, in the thinking, and in the behavior. But back to the oval of the body sensation. Second teaching tool is this zone of well-being. And on the I won't jump ahead too much, but on the back of this teaching tool and handout is this version, which we'll talk about. But in the zone of well-being, which is sometimes referred to, so from something called somatic experience as experiencing as the window of tolerance, or the resilient zone, this is our bodies, all people. So in our zone of well-being, we notice when we're getting activated. We have tools and skills to keep us in this zone of well-being. We notice when we're getting droopy, have tools and skills to keep us in here. Some of you may have heard of the fight or flight response. So that's a survival response of our nervous system. Usually around here, we'll say things like if there was a bear coming down the hall, we don't have to just have a discussion. What should we do? I don't know. I mean, our nervous systems are wired up to survive. And so the fight or flight response might happen: heart pounding and racing, breathing more rapid and shallow. That's to get the oxygen in and pump it to the arms and legs for the fighting or the running. Metabolism gets pulled away from digestion because we don't need to be digesting our food if we're fighting or running. You may sweat, cooling the body for, guess what? The fighting or the running. And so this is a response. That's a beautiful response, but it should be like a fire alarm. It should not go off very often or last very long. Anxiety, for the most part, is living up here in this high arousal. And let's think back to those different models of trauma, the ones that were historical and persistent institutional and cultural. We may find that we're living in this high arousal for various reasons, but something that's important for us to know is that it's not just an experience of anxiety or distress. The experience of anxiety or distress is a reflection of the elevated stress hormones in the body and in the nervous system. And there is what I refer to as the stress tax. If I live up here much of the time, there is an impact on my body and my nervous system over time, such that I get increased likelihood of a whole number of chronic health conditions. There's a lot of research around this. Some of it comes from our work on adverse childhood experiences and the many decades later in adulthood of the health issues that show up. But this can be increased risk for cancer, for diabetes, for cardiovascular disease. And part of it is thought now that it's because we're up there in this high arousal zone with the elevated stress hormones, which are creating inflammation and other things in the body. Here's life happening. So a trigger occurs. It could be something happening outside of ourselves, the news, a sound we hear, could be our own thoughts. With that trigger, it may throw our nervous system out of our zone of well-being into the high zone, let's say, where we experience it as irritability, anxiety, anger. We may get thrown into the low zone where we experience sadness, depression, fatigue. We may isolate. You can actually have both, which would be like being in a car that's turned on and in park, but you're revving the motor. So kind of paralyzed, but vibrating. All people get thrown out of their zone of well-being sometimes, but it's a problem if it happens too easily, too frequently. We go too high or too low and get stuck there. Again, remember, there's impact on our health, certainly our emotional health. These experiences being stuck down at the bottom or the top don't feel good, but it also impacts our health over time. And so that's the second of our handouts. Also, we have what is in my office, I give this to everyone I work with and also in the community. We call it the blue card, and cardstock and a color seem to make a difference. But I go over with everyone, and this is sort of one of our basic teaching tools, is 6 steps to emotional health. This is how it looks as a handout in the manual, but typically in practice, we make a little half sheet, and this can be used in a lot of settings and standalone. We talk about really how to stabilize body and mind with sleep, eating, movement, which we used to call exercise, but no one really wants to exercise, so we call it movement. And actually in a lot of places that are less economically advantageous, people are moving all the time, right? They're moving all the time, and so that counts. But then we clearly also know that doing something pleasant every single day and paying attention to it, the science is very clear that that's supportive of emotional health and effective for treating depression. And then we've got focused breathing and mindfulness. So many other tools that are here. If anyone who's on this is interested in talking to me further, I think here my email, I don't know if these slides are going to go out, but my email is right here, and it's on, actually it was on some of the materials. You're welcome to contact me. This is a little white half sheet with mindfulness resources we hand out. So I think I'll perhaps, Reza, is it time for me to, the rest of what I have here, and if you get the slides, are the rest of the curriculum. I'm happy for you all to have it. And again, you can ask me for the materials, but that's an understanding of trauma in some ways. There's lots of different ways to think about it, but sometimes we get sidetracked into one way and then it doesn't make sense. Some basics on resilience, which I think a lot of people and me for many years were not aware of, and then tools and skills. How do we get them out to the community to meet unmet mental health needs?
Thank you so much. That was an amazing introduction to mental health and resilience, and also this amazing intervention. So I use my microphone privilege to ask a couple of questions first, and I see there are some questions in the Q&A. So first of all, so like this is an amazing mix of tools and modules for the training. So what social skills are needed based on your experience, or what social interventions you think should be a part of this, or is based on years of working on that, like how people use it in the context of their communities?
Well, so people can do it a lot of different ways. And so we don't want to just be someone saying, oh, I know, here's an idea. I mean, that could come across as real bossy. So we gave a badge. We have people, sometimes we're training all of the staff in an agency or something like that. And what I find is so often people are using the ideas, I mean, I do too, for themselves, right? So they're improving their own mental health. But we have had people where they were sort of the outreach in their neighborhood, or they were handing out the blue card at our homeless service center, and they have it for people right when they come in, or in our domestic violence agency. They were also using this as well as some of the other tools I didn't get to, but hopefully you all will see it in the slides, something called structured processing, which is really, we just call it a guide for how much to think about things. And so it can be, people can tailor this to whatever they would do, but there is a badge and a certificate that says you've had some special training. If you were going to, for instance, at a church, this would be our context, have, one Sunday a month, the Community Wellbeing Mentor is available between services. I've done a couple of trainings with community health workers, and so that they have this training as well. So they're a community health worker and they're getting whatever training for that. And they also have these tools and skills.
So the handouts and cards could be distributed like by the people who are trained through the program.
Absolutely. And they get a folder that has the manual in it, but it also has, for instance, I used to give a lot more, but then, now people can ask me. So 10 copies of 10 copies of this, 10 copies of that, 2 copies of a lot of other things. We have some safety resources we give out for everyone with some blanks to say, add your, whatever your safety resources are in your community. So they have a few extra copies to start with. And agency-wide, sometimes, or agency-wise, I will send them and have done this, sent all of the materials in electronic version. And I am happy for people to change the name. This blue card was adapted, has been adapted a number of times, but was adapted for someone working at Rikers Island with youth. And so they made it look completely different. Somebody in Canada made a bunch of steps and it made a lot of sense to me. So people can take these and make them much more relevant for their context. That's fine.
Very interesting. Thank you. So we have a couple of questions in the Q&A. So Anaita, you want to start and then I will read the question. So if you have a question yourself.
Yeah, thank you so much. This was really interesting. So have you had any evaluations to see like the impact of this type of training, like before, after type of assessment?
Well, so we have only collected qualitative feedback, and we've gotten some much after because we tend to see these people. This particular grant, so we got some grant funding for this through our mobile outreach clinic, and it was, unlike most things we get, it was the Just Do It grant. And so we have had, discussions around, we're giving things to people. In some of our contexts, we also, and I never tell anybody this, but sometimes we give gift certificates to people because we're honoring that they have come for this. So we give a $25 grocery store gift certificate often, but nobody knows they're getting it. So not that I would mind someone coming just to get a gift card because I think they're going to learn something, but we have conversation around what are we asking from people, right? And so in mental health, we're doing assessments. I've done projects where we're doing that PHQ and GAD, and perhaps it's to people who come to the mobile clinic or are unhomed, and then can we follow them up? And so far, until there's a next iteration, we're just getting qualitative feedback because we really haven't come to terms with that. We would like more data to be able to say that. And I put 2 little quotes up. We have a long list of feedback from people, and I've had people contact me later, but we're not approaching it in that way. And so far we don't have to.
Thank you.
Sure.
Thank you. So I read through the questions in the QA. Donna Golden asked, it's a series of questions. So is there any ongoing mentoring to those after training? So basically the follow-up training. Let me read the second one. What's the impact of educational level of trainees? I work with the pre-literate Afghan women. So like I pause here, give you the opportunity to answer that, and then there are other questions.
Sure. I mean, we've tried to have for our US population, the level of literacy be, I think, what are we usually aiming for? Like 6th grade or something like that. But we have had, for instance, that blue card, the 6 steps to emotional health, put in graphics. And so, we are happy for people to take it and in their context, look at the concepts. So for instance, we talk about sleep. And if I'm at our homeless services center and it's someone who's homeless, I mean, this is something I worked with, so I'm saying 7 to 9 hours of sleep. Ha ha ha, if you're homeless. But you know what? It's still the science. And so I feel, pretty strongly that I want them to know what the science says that their body needs, per night. And for everyone I speak to be off all electronics at least 30 minutes before you go to bed. I don't care who I'm talking to, that's an issue. But, if you're in a dorm or sleeping in a tent, you may not be able to get that. So I still want to tell people this is what the science says, because everyone deserves to know that. But I'm happy for people to take this, like the one for Rikers Island, because the way that I'm presenting things to you is not going to really work with a bunch of teenagers who are incarcerated. Our initial model was a series of 3 trainings and then some follow-up. What we found is nobody came for it. And so I give people my email and then also my personal cell phone number. And so I am available at all times. I've had a few people contact me, but not too many. And so would this be more impactful if I required more of these people? You know, I initially gave out to everyone a log form and was going to have them log everyone they had contact with and get back to me, but that didn't last very long. So right now we're still in the real community part of this behavioral health project, which is to try to train as many people as we can on these basic concepts and hand them into their hands or download into the Zoom chat as many of the materials as they would like.
This is very good. So there is a follow-up question about the fees for nonprofit organization. I will you can provide your email if people want to contact you directly. So
sure, I'll put it in there. Right now, there is no fee. So we have had funding to for last year and this year. So until the end of this year, and we'll see what funding happens after that. If someone asks me, we just say yes, and I just provide it. Now, if our funding, you know, if it was really a 1 year and then they renewed us for another year because they're really just hoping to get projects going, we may develop a different model for funding, but hopefully it won't be very much. But for instance, I trained 23 people yesterday. I went in person. I took all the materials and I gave them gift cards. So, you know, sort of like we're supporting them. And this was a whole bunch of people who many of them are disabled and work with people who have disabilities. So I will put in the chat my email, or I don't really see, I guess I put it in the.
And also, I wanted to get your permission to share the slides. We upload this video on our website, and then we can put the slide set, because I saw that you have some interesting links that people can follow.
Yes, and I can put I'll put my email in here too.
Thank you. So you have to share it with everyone. So in the chat, yes, you did. Very good. So Carol's email is in the chat if you want to reach out to her. There was also another question that one nonprofit organization showed interest, so I promised that we will share your contact. So
Great.
last question by Donna is a very interesting question. So sometimes members of a community do not want to talk to people in their community for fear of gossip and other issues that they know hearing about their problems. Has this come up as a problem in your experience?
Well, you know, this is not so standard mental health. People often think of it as we're gonna talk. I said just, I don't really mean that, but you know, we're gonna just, I said it again, but you know, we're gonna talk about the issues. This is really a skill-based approach, and that's really how I work. So I have not so much, but what I actually have found is in these trainings, like for instance, the one I gave yesterday, several people were very self-disclosing, you know, in a way that I have to kind of keep some bounds on. A group is only as good as its facilitator, right? So, so people were self-disclosing. I think if someone can come and say they want an appointment or they want to have a meeting or can they meet with you, we're not asking them to tell us everything they're going through or even share any of that. We might say, let me tell you some things that help stabilize mood and manage anxiety, because really those 6 steps, I think without them, we're not going to be able to manage mood or anxiety. And there may be other things that are needed, but I did not say earlier, I worked for 20 years in the outpatient department of our psychiatric hospital, our university psychiatric hospital, with many people who'd had even recent suicide attempts. And so, you know, we can teach people things that can help them in a lot of ways, like that daily pleasant activity. There's a form in there for that. And I have found, and the science supports it, that's so impactful. And that's without anyone telling me what they're going through.
Very good. Thank you. And there is a comment about the similarity of this program with other similar or other alternative programs. And there's an example, community resilience model training from the Trauma Resource Institute. So can you give a comment about like similarity and differences between different programs and how people can navigate them?
Yes, yes, and I am familiar with that. And at least when I was familiar with it, they taught, I think, four tools and has a big training model. Ours is much more, I think I used to call it, I can't remember what I called it, but somebody else said grassroots. So we're grassroots. We're not asking people to commit a lot of time. And it does include things that are really standard for mental health that are across models. So grounding is there, focus breathing. We teach a lot of that. I'm trained in, I don't know if you all are familiar with mindfulness-based stress reduction. I'm trained to teach that. We have developed a little mindfulness protocol here. So I think it's great to have resilience models. I think people go about it in different ways. Ours is really a sort of a sharing low, sort of a low burden model.
And I think that's a kind of a program that we need for resource constrained context, that like people have limited opportunities to participate. Oh, I see. Yeah, so there are comments thinking about that. So we are almost at the cap. Thank you so much, Carol. That was an amazing introduction, an overview of the big picture, and also a quick tour of your amazing program. And I am sure that people are interested, including ourselves, are interested in adapting and using it in other contexts. Thanks. I want to thank everybody for participating here. I put the link for registration for the following sessions in the chat, so you can register for the following sessions. Just a quick reminder that our next session will be on August 6th, the same time of the day, like noon at Eastern time, and Mr. Jess Kohler, who is the Executive Director of CTIPP, which is Campaign for Trauma-Informed Policy and Practice, a nonprofit organization that has done some innovative work in the context of community resilience and community action, will give us an introduction to their activities. Again, Carol, we are looking forward to having your slides to put them on the website. And these sessions will be transcribed and translated into Farsi. So for the people who want to use it in other languages, again, we have the resources to translate into Farsi. And all will be uploaded on our website and will be promoted on our social media. I want to thank you again for sharing your great experience with us, and looking forward to more
Such a pleasure. I so appreciate the invitation and the opportunity. Thank you so much.
Thank you so much, and thanks everybody for attending. Have a great day. Bye-bye.
Thank you.
Great.
Take care.
Bye.